Good morning, and welcome to this HSJ event. My name is Ben Clover. I am the Bureau Chief, one of the Bureau Chiefs at the Health Service Journal. And yeah, thanks for coming to How to Restore Cancer Services After COVID. We're going to have a discussion for about 45 minutes, and we've got three really interesting guests to kind of talk to us about it. So hopefully there'll be something of interest for everyone. Just before I kind of get started on what we're going to talk about, it's just to say you should have on your Workcast platform a way of submitting questions. Do please submit questions as people are talking, as things go on. We're going to do all the questions probably in the last third, from about 11 to about 15:15 when we'll finish off. But do please send your questions through as they occur to you, so as we've got a good stock to start with, and just so as you don't forget them, and also so as our panel can have a look at them and think about them. So, how to restore cancer services after COVID. I'm sure no one needs telling. It's been quite a year, and actually, cancer services have had to be restored kind of twice, in some cases, kind of more than that. It's affected every part of the pathway, I think it's fair to say, from GP referrals to screening services to diagnostics to actual treatment, to care, even at the palliative care end. But that said, there's been extraordinary work done across the specialties in keeping services going. So for every case where there's been cancer surgeries cancelled or PT surgeries cancelled, there's been really exceptional work done on keeping chemotherapy services going, radiotherapy services going, diagnostics going, even in the face of a situation where the service was already tremendously stretched even before all of this. So yeah, it's been quite the time, as I'm sure you all know. I'm going to introduce our panel. We've got Linda Thomas, who's the Chief Executive from Macmillan Cancer Support. We have Richard Mitchell, who's the Chair of the East Midlands Cancer Alliance and the Chief Exec of Sherwood Forest Hospitals, and Ian Vousden, who's the Programme Director for Kent and Medway Cancer Alliance. So like I say, we're gonna go through it, and I'll hopefully get a kind of discussion going with people's questions. But I guess the first question I wanted to really put to everyone, and if Linda, if I can put this to you first, is, I mean, what have been the lessons from the first round of COVID, from that first period in March, April for you?
Yes, thank you very much indeed, and good morning everybody. It's lovely to be here talking to you today and delighted to take part in this panel event. So I think it was really actually quite hard to cast my mind back to March last year. So much has happened in this last year. It feels like a different world away. But I think, you know, looking at it and thinking about how things were last March, I think some of the lessons that we've learned and what really happened, I think there are a few things. The first thing I think is there was a very strong stay-at-home message at the beginning of the pandemic, and patients believed that stay-at-home message meant them to stay at home and to stay away from their primary care and GPs as well. And ultimately, this did mean that 35,000 fewer people were diagnosed with cancer during 2020, and you know that is a huge issue now for the system trying to catch up with those 35,000 diagnoses. And I think we got on top of the come forward. We didn't mean if you were ill to stay at home message, but it came obviously quite late in the day. And, you know, I want to say I'm not criticizing anybody for this. We were dealing with the most unprecedented situation ever. But that late information going out really, and then people came back in dribs and drabs. So the first thing was, as you said, fewer people diagnosed. Then I think there was something then around, you know, the pathway and systems having to get up to speed very quickly with a hugely urgent COVID issue, and perhaps inadvertently the deprioritization then of services around cancer just meant that there were a lot of cancelled and delayed procedures. And cancer wasn't protective during wave one in the same way as it has definitely been protected over the winter now. And I think therefore then, you know, there were some bits of the pathway, particularly around imaging. So, you know, endoscopy waiting lists grew by 69% during this time, and for very valid reasons around patient protection. But actually the unintended consequences of that was that it was just so much slower getting through the system. And I think there was a lot of uncertainty for patients around that time as well. Perhaps patients who were already within the system, who were hearing that their regular scans and follow-on appointments had been cancelled, and asking Macmillan questions like, am I getting better? I haven't been examined for months. A phone call just isn't enough. So there's a lot of anxiety for patients as well. I think there were some issues around workforce redeployment, and we certainly saw that at Macmillan, where we had Macmillan clinical nurse specialists redeployed away from cancer into other areas, which just meant that capacity then was reduced for people. And some of the things that actually I've been talking about around, can I get a phone call, just simply weren't possible because there just weren't the people there to do that, actually. And then finally, I just wanted to talk a little bit about the use of the independent sector, which of course came in during wave one as a block contract. And, I think what we've heard certainly during this part of the pandemic was that capacity was just not used to the fullest potential and was patchy around the country, actually. So there are so many lessons that we learned from wave one, and many of which I'm sure we'll go on to talk to now as we've been dealing with the winter crisis. But those probably are the things that are top of mind as being the most important, both for patients and professionals.
No, thanks. That's really interesting in terms of things we could have done differently. I remember being very struck by like the redeployment of lung cancer specialist nurses in particular. That was something where that specialism said, there just wasn't the support then for their clients, and actually, because it's such a fast developing one, that we might already have lost something like a third of those patients who might have received curative treatment. I mean, it is very scary when you get into the real decisions that people had to make in the face of it.
Yeah, I think if you're dealing with lung in particular, obviously, like COVID really affected lung cancer patients. Some of the symptoms were similar, so people weren't seen in that way. Screening stopped for around, the targeted lung cancer screening program. So certainly screening had an impact as well there.
Gotcha, yeah, and some of the individualized, localized programs were kind of slow to restart there for reasons I still don't quite understand. Anyway, Richard, I wondered if we could come to you. You chair the East Midlands Cancer Alliance. Kind of, what was sort of the big, what were your big takeaways on sort of lessons from the first wave? Oh, sorry, I don't know if do we still have Richard? Oh, hello. Sorry, Richard, can you hear me? I can see a mouth moving, but I can't hear you. Okay, sorry, just while we get that sorted out, I think we might have to go to Ian just while we get you sorted, Richard, just because, so I don't know if everyone else can hear, but I can't at this point. Ian, are you there?
Yeah, hi, good morning, I'm here.
Hi. Sorry to skip over in the order from Richard to yourself. It's just he seems to be having a little bit of trouble with his audio. But I wonder if I could basically put the same questions to you, kind of like Kent Medway. Obviously, all patches were pressured, but a very pressured patch in terms of COVID. I just wonder if I could get your reflections on lessons from the first wave.
Yeah, of course, no problem. And good morning, everyone. Thank you for inviting me to be involved in this discussion this morning, which I think is really important. So my reflections, I think, differences between wave one and wave two, specifically for us, I think is one of the key things is clinically, our teams across the patch learned a hell of a lot from wave one in relation to COVID and how to manage COVID. And coming into wave two, we were in a different dynamic, I think. So during wave two, even at the height of case numbers across our geography, services and urgent diagnostics continue to be prioritised through wave two. And just to put that into context, I think during wave two, as was the case in many parts of the country nationally, we saw three times as many patients in hospital poorly with COVID than we saw in the peak of the first wave. And even within that context, cancer services continued for patients across the board. So if patients needed to come in for urgent diagnostics or needed to come in and have their urgent cancer surgery or radiotherapy or chemotherapy, those services were still offered to patients. So I think, the first main point I think probably would say, even though I'm not a clinician, is that the clinical teams learn a lot in relation to how to manage and clinically deal with COVID and set services up from lessons from wave one. I think the other point I would make is particularly around diagnostics. I think Linda touched on this. So during wave one, I think diagnostics particularly suffered in relation to provision of service, more so than treatment. And I think in wave two, due to the infection prevention control guidance that was gleaned and learned from wave one, it meant many of those services could then continue within the context of wave two, knowing what needed to be in place to keep both staff and patients safe in that context. So the diagnostics piece continued in wave two, which clearly was hugely important in terms of getting patient access to timely diagnostics. And then I think just in terms of how services were configured within wave two, I think alliances and trusts and clinical teams across the country were able to plan to a certain extent for how those services could be maintained, could be COVID protected, or delivered where possible in green and safe areas for patients. And again, lessons learned from wave one about how that could be done and delivered carried through into wave two and held us in really good stead. So I think for me, those three areas were key in relation to what we learned from wave one coming into and out of wave two.
Gotcha. So there were a couple of specific changes in guidance, weren't there, from some of the professional bodies involved in some of the diagnostics, as I understand it, which meant kind of things that just weren't possible in the first wave were possible in the second. Is that right?
Yeah, absolutely. So specifically within, and the example I would give is within endoscopy services.
Yeah.
So there was a concern during wave one that some of the procedures were aerosol generating and therefore a risk potentially in relation to both the staff and the patients that are undergoing those procedures, particularly around colonoscopies. And obviously coming into wave two and out of the end of wave one, national guidance and clinical guidance changed in that space. So we were able to deliver services in a safe way with the assurance that they would be safe for both patients and the staff involved.
Gotcha. And another thing I'm kind of curious to pick up about, I was interested in your reflections on the first wave is, we're going to hear from Richard in a minute, but kind of I think Richard's patch has got its kind of tertiary cancer provider sort of on the ground next to it, whereas as I understand it, Kent Medway, it's sent a lot of its tertiary cancer work into London. I just wondered how that went in the first wave.
Yeah, of course. So you're right. So in Kent Medway, some of our specialist cancer surgery work routinely, so not just in the context of COVID, but routinely flows into Southeast London. So our pancreatic, our esophagogastric, and our lung cancer patients go into Southeast London for their cancer surgery. So during wave one, London configured their services to have green hubs, surgical sites available for patients. In wave two, the model was slightly different, but they were still able to access tertiary surgical services for those patients, and they were triaged accordingly and then offered surgery. So yes, some alliances and some alliance geographies have many of those specialist surgical services contained within their geography. Ours flow up into Southeast London.
Gotcha. And that was something that changed from the first wave to the second, was it? Kind of the because I mean I know a lot of the problem in the first wave was the diagnostics, but there was still some. I mean, there was that sort of week where basically nothing happened, but there was still some disruption to surgery and treatment. But I just wondered how it was different between one and two, like what specifically changed with regard to sending work up to Southeast London.
So from our perspective in Kent and Medway, it didn't really change between wave one and wave two. So at the beginning of wave one, as you quite rightly say, some of the services were disrupted in London in relation to configuration of services, but they quite quickly were able to reconfigure their cancer services to offer those services to patients. So we refer our patients into those specialist MDT discussions, at which point a decision is made about where they need to be treated and how they're prioritised. And then that continued into wave 2. There was some minor disruption within wave 2 at the height of the second wave, but it was only minimal and only for a short period of time.
Gotcha. No, fair enough. And like Linda brought up, kind of the use of the IS independent sector in the first wave. Kent doesn't have that much IS provision, does it? Was there much call on that in the first wave?
So I think it's probably fair to say that during the second wave, and again in terms of lessons learned, during the second wave, we've probably channeled more cancer surgery into our independent sector colleagues locally than we did during wave 1, and we continue to do that. It tends to be the surgery that what I would describe as the non-complex cancer surgery, if there is such a thing. So for some of those breast patients or suitable gynae patients, and some of the more non-complex surgical work has been going into our independent sector colleagues, but actually the complex work, which needs ITU or HDU support, is still tending to be done at the acutes within those green areas.
Right, as they always were. Interesting. Okay, I'm gonna throw that question over to Richard as well. Hopefully, you can hear me and we can hear you at this point. Richard, hi. Hello, Richard. Can you hear me? Oh dear, I'm sorry. Seem to be inaudible. Again. Yeah, it seems like we still can't hear. Richard, I don't know if you can hear me, but there is a number you can dial into. I'm sorry about this, Richard and everyone else. Well, look, while we wait for Richard to come back in, and I'm sorry about that. I wondered, Linda, could we come back to you? I just wanted to ask kind of where we are now that we've done the second wave, and I know we've already had some comparisons of like how the first and second went, but from what I'd been told in London, kind of there was quite significantly less IS capacity in the second wave. Independent sector capacity in the second wave than there was in the first wave. And I just wondered, from Macmillan's experience, has that been the case like across the country, or was that more of just a London issue?
So I don't know the whole situation across the country, but I suppose if you're asking me a generic question on where we are now,
yeah.
Obviously through information at Macmillan and also through my role with the National Cancer Board at NHS England, so I am privy to sort of data through that. The picture seems to be so much better during this pass, and I really agree with what Ian said about so many lessons learned and actually so many new practices put in that just stopped during wave 1. So looking at all the data that's coming through, it looks like actually referral rates are at pre-pandemic level. Chemotherapy and radiotherapy has held up really well. There was some disruption to surgery, certainly at the beginning of January, and certainly in London and the southeast. And I think some of that was reported, but I don't believe we've seen that everywhere else. And I was chatting to a colleague at Clatterbridge last week, and she was assuring me that surgery actually in her area is as good as it was pre-pandemic. So I think we are seeing cancer services carrying on. What I would say, I think, though, is that there's still a long tail with regards to some of the things that we would consider at Macmillan to be really important, specifically around looking after the holistic needs of patients. So not just treating urgent medical needs, but, I think there's a lot of issues around anxiety. I think there's a lot of issues around people perhaps not quite understanding what's happening to their treatment and not quite getting the same level of communication as they were before. We've certainly seen patients being very anxious, having to go into hospitals on their their own, for treatment, and sometimes for consultations in the initial stages. And that's caused a lot of anxiety. So we at Macmillan are probably having to pick up quite a lot of the slack around that. And, you know, I suppose one of the good things about the use of the voluntary sector is we can do things at pace that don't perhaps require the same amount of regulatory oversight that might exist within the system. So we've set up, for example, a telephone buddies system where we can talk to people about these. We've set up counselling using actually some independent sector capacity jointly with Macmillan to be able to support people through that. So the patients can perhaps get the help that. I don't think this is because people in the system don't want to help people, but, you know, we are dealing with, I think the Health Secretary was on the Today programme this morning, still talking about more than 30,000 people in hospital with COVID. So it's good for the voluntary sector to be able to work alongside the system, because things are very much not back to normal in many of the areas, even though the stats would show that, you know, for things like urgent referrals, they are back to normal.
Yeah, no, that's an interesting point. Kind of on the headline figures, we've got referrals back through as pretty much as they were, which is great. But there's still tremendous pressure on the acute systems. There's just so many of the things that would normally happen, that those things like you talk about that might not seem like key parts of the patient journey, but are actually very important to people, like the just being given information and counselling and similar. Aren't happening. I just wondered, kind of, what with the new variants and that kind of thing, have your teams who sort of look at that end of the of the problem, who look at sort of people's perhaps hesitancy to kind of go to healthcare settings, does it feel like that battle's been decisively won now, or is there any signs of sort of resurgence in people being like not wanting to go to any healthcare setting, you know, kind of not wanting to go to the GP to get their referral or similar?
Yeah, I mean, I think the thing that we don't know is what happened to those 35,000 people that resulted in 35,000 fewer diagnoses. And for each and every one of those, that's a person with a cancer diagnosis that still hasn't come through the system. So it's hard to say whether or not we're catching up with those, and then there are still patients that aren't coming forward. And, I mean, this is unscientific data. This is a hunch, but I suspect that actually there are still people, and potentially people from marginalised communities, who still aren't coming forward. So, you know, we know that some of these things were issues pre-pandemic, and it's just exacerbated everything. So, you know, I don't have any data on that, but I think we will probably look back on it and accept actually that for some parts of in different communities, that actually there was a big issue, and there is still a bigger issue to be tackled. And, you know, I think looking at things like the inequalities that we've seen throughout the pandemic and seeing, well, where are we now with that, will be really interesting, but we don't capture real-time data around that.
No, I mean, it is still, for all of the improvements, it's still pretty humbling that we know there are people out there who should have come through in a normal year, 35,000 of them, and that haven't. I mean, I guess I wonder if, Ian, if I could throw this to you. Kind of, I know there's an awful lot going on, kind of just on the day-to-day work, running a cancer system, but kind of, have you received kind of much guidance, or is there a sort of homegrown sort of bit of work to look at, you know, who might we have expected to come forwards, who haven't, and where can we find them?
Yeah, I think it's a really important question. I mean, I'm just reflecting back on some of Linda's comments, which, you know, I think are absolutely true. I think we've absolutely seen a definitive change in relation to wave 1 versus wave 2 in this space. Certainly the numbers, as you've both alluded to, suggest that referral numbers are kind of back up more or less to pre-pandemic levels this time round, where obviously in wave 1 they dropped significantly because of the messaging around, I think, you know, stay at home, which I think in the context of urgent cancer symptoms and diagnostics wasn't particularly helpful. So I think we have seen that change. I think the other thing that we are hearing anecdotally, and it is starting to appear in the data, is that this time round patients do feel better protected and safer coming into hospital. But ironically enough, now we're starting to offer vaccinations for clinically vulnerable patients that are cancer patients. We're hearing some noise, and again, the data doesn't necessarily flow with this yet, but patients are quite keen to wait till they've had their second dose in relation to then coming in and accessing some of those treatment services. Now, it's early days with that, and clearly there's some messaging that we need to make sure that it gets out appropriately into the system in relation to not stopping cancer treatment due to the timing of the vaccination program. But interestingly enough, we might see the impact of that in the short term.
Gotcha. No, that's interesting. That's increased people's confidence. I was just struck by. Sorry, unless we can get to Richard, I'm gonna bring in
Hi,
some
can you hear
questions.
me?
Oh, brilliant! Hi, Richard.
I'm so sorry. Massive apologies. Let's blame COVID for this.
There we go. So sorry to the technicals have kept you, Richard. I don't know what you could hear of that.
A bit at the beginning.
Brilliant. Okay. Well, I guess what I'd like to ask you is basically what I've been asking everyone else since the beginning is, what are the lessons from the first round, and just key kind of like what do you think are the key things for restoring cancer services now? Like what are the key things like you're working on in your Cancer Alliance to restore services to how they were?
So thanks for the opportunity, and obviously huge apologies and embarrassment for inability to get the IT to work earlier. So in terms of lessons from the first wave, I think in the Midlands, like many areas of the wider country, we've probably experienced 3 discrete waves of COVID. And what I heard from Linda and Ian, our views are very similar to what they described. So I think you can, in terms of the lessons learned, probably view it through 3 lenses. The first bit is about the service provision. So it was clear in wave 1 that we collectively took the decision to stop providing most of our services. And I think with hindsight, it's easy to criticise that, but I think that would be incorrect. We were experiencing something new for the first time. We didn't fully understand it. So our actions at the time were logical, but it's clear, and the position has obviously evolved over the last 12 months, that we don't need to stop everything in terms of service provision. Also, we stopped a lot of training throughout this, training of clinical colleagues because of inabilities to travel, requirements for redeployment, standing services down. And I think we'll now have a number of clinical colleagues who need to complete their training over the next couple of years to ensure that they have the skills, the satisfaction, the motivation, etc. And in terms of service provision, I certainly heard colleagues reference, we learned about the importance of working with the independent sector, opportunities to recalibrate our pathways within our organisation, so trying to identify green pathways. There was learning that the regions who had access to separate cancer hospitals and facilities, that was beneficial. We've obviously moved more to video consultation and different ways of supporting patients navigate their way through the services. So lots of learning there that's evolved over the last 12 months. That's the first bit. The second bit, and I heard Linda and Ian touch on this, is about our messaging to the public. And we know that right at the beginning, patients understandably were concerned about accessing primary care and secondary care. We know that 2-week referrals dropped off. And in some areas, we've seen a return to levels we were seeing previously. So the communication of ensuring that our services are safe and open for people who need to be in here, and patients on cancer pathways clearly need to be accessing our services, was a key second point. And then I think the third of the 3 points in terms of the learning for me is recognising that the welfare and the well-being of our colleagues is central to this. We've all been living with COVID in our working and our personal lives for 12 months now, and I see colleagues who are worn out, who are incredibly tired. And I think for us to restore our services effectively, it's not about just focusing on the next couple of weeks or the next couple of months. It's a recognition that restoration will take many years, and we need to support our colleagues not only for their own personal benefits, but also people who are able to return to work productively. That can only be good for our service provision going forwards. So they were my 3 points over the last 12 months.
No, thanks very much for that, Richard. And it's it's something I hear absolutely everywhere and from everyone I speak to about the impact on staff. I'm sure we all know people who've gone off have had to go off with stress, just because it's so intense for people. I want to move to questions from our viewers. So thanks very much for everyone that sent them in. And if I could come to you first on this, Richard, if that's okay, because I'm kind of interested in how diagnostics works on different people's patches. But I've got a question from Alison McKay, Four Ways Healthcare. How do we see the impact of on diagnostics imaging? We still like to see patients needing to be rescanned, given the time that has passed since their last assessments, treatments. I mean, how is diagnostics looking? I know it was already very stretched, and that we're already using like scans and vans, pretty much the entire independent sector capacity of that's available. I think they're commissioning new equipment from that. But yeah, if I could come to each of you in terms, if I could go Richard and then Ian and then Linda. Yeah, on the diagnostics imaging piece specifically, and also the rescanning, which hadn't occurred to me, but I guess, is that an issue you've come across?
So I'll come on to the rescanning piece in a moment. In terms of diagnostics, as you describe, I think we need to be honest here and recognise sort of the question about where are we recovering to. Pre-COVID, if it's possible to remember life pre-COVID, so 12, 13 months ago, cancer services across the NHS collectively were under huge pressures, all of the different component parts of it, and diagnostics was certainly a part of that huge demand coming through the diagnostic pathways. You quite rightly described that there's many different ways of increasing diagnostic capacity, and 12 months ago we were trying to use every opportunity to safely increase productivity. It's clear that because of COVID precautions, infection prevention control, and also staffing shortages, diagnostic productivity has dropped off over the last 12 months, despite the immense effort of everyone involved. I think we need now a period of considerable planning certainty. And if we were to look to investment within the cancer pathways, I think diagnostics would be the key place to be investing, not only within the NHS core capacity, but continuing to use the independent sector and elsewhere. The point about rescanning, I must admit, I'm non-clinical. It's not something that I have thought about, nor possibly have been involved in conversations. But yes, I would imagine if there has been a lengthy period of time between an initial scan and now, it seems almost certain and logical that patients would require a second scan.
Gotcha. Ian, is that something you've come across?
Yeah, hi. So just from a clinical perspective, in a similar boat really, I probably couldn't comment specifically on the rescanning provision piece, although would agree with Richard that potentially due to the impact of services in the context of COVID, that might be the case. I mean, just in terms of a broader question around diagnostics, I think it would be fair to say that for certain diagnostic modalities going into COVID, there was a challenge coming into COVID. Obviously, that's been exacerbated, and coming out of it, I think we have a job on our hands in relation to recovery of services in relation to moving things forward. But I think on the horizon there is probably some potential light at the end of the tunnel in relation to the output and outcomes of the Richards review and the potential around community diagnostics, which I'm not going to go into too much detail on this call, but I think that there is potentially a way to help provide diagnostic services in a slightly different way moving forward.
Gotcha. Yeah, no, that's a big old piece of work, and I think HSJ does have another event on that next week. Where we'll be speaking to Mike Richards. Linda,
Can I just pick up on the issue of the rescans, actually, because I think and just talk about it from a patient perspective. This is probably the largest volume of calls and anxiety that we've seen over the last 12 months, where patients are already in the system, so they're not waiting for new diagnosis, but they are required to go for regular scans, and particularly people with metastatic disease who are on, treatable but not curable pathways, but they're really important pathways because patients can live for years and decades with treatable but not curable cancer. And this is where we've heard a lot of anxiety anxiety from people who, their chemotherapy regime relies on them having regular scans. They were unable to have scans sometimes for up to 6 months. Then when they had the scan, they go in and they'd realise that actually their cancer had grown, and the chemo that they'd been given just wasn't appropriate for them, and they could have changed the regime sooner. So I do think that we will see a lot more patients who fall into the category of people who just require regular follow-up and scanning and imaging, and haven't really been able to access that properly over the last 12 months. And there will be, there's going to be impacts on people's quantity of life as a result of that. So I think that is perhaps a patient cohort that when we capture the numbers around who's in the system and what's happening with diagnostics, we forget that actually that is just as important. And preventing secondary cancers and being able to pick things up early from a patient perspective is enormous, actually, because and I would hate to see us go backwards in that area, and what we probably have done over the last 12 months.
Yeah, I think it's inevitable we're going to see our position on the sort of the international comparators on mortality go down. I think that's been documented by proper researchers. I just want to bring in a question from Suzanne Willis, who's the Cancer Strategy Director at Southampton. She makes a point. She said, I'm concerned that increases in capacity perceived by the public actually rely on the same relatively constrained group of staff who are probably exhausted. I'm sort of interested in all three of your perspectives on her question, which is basically about how are there any ways to increase capacity at this point? Like, are there any levers that are yet to be pulled on this? And and that would apply at a national level, Linda, as well as at the actual Cancer Alliance level. Ian and Richard, whoever wants to pick that up.
Can I just say something about workforce, actually? So I think for us at Macmillan, this is the biggest thing that we're hearing. And I've heard from Ian and Richard about colleagues in the local systems who are exhausted. This is something that we see all the time. So it really bothers me that we are expecting the same people to be able to, first of all, live through wave one and then come out and immediately start restoring cancer services, and now have also had to go through probably the most difficult winter the NHS has ever faced. We're not going to be giving those people 2 weeks off in April and May and basically saying go on holidays and relax. We're going to be demanding that cancer services get picked up again. And I think it is with the same people, and it's a real worry. I know it's something that worries everybody at national level as well as at local level and us in the voluntary sector. But I think unless we see some really urgent action on a proper workforce long-term planning strategy with money behind it to be able to both boost capacity and do something around different ways of working, then actually this is going to be a really big ongoing problem. We had a problem with workforce shortage before going into the pandemic, and you've just got to believe it's going to be made worse at the end of this. And I take my hat off to anybody that's been out there keeping services going over the last 12 months. You see people living in caravans in the garden. You can't carry on like that forever. We've really got to look after our NHS staff coming out of this. Otherwise, they're not going to be there in the future for us.
Absolutely.
Can I just add to Linda's point here? So yeah, absolutely in agreement. Let's be honest, it's unrealistic to expect the group of people who've been actively involved in COVID care for what's been over a year now to switch and fully restart normal non-COVID care immediately. I think we have to be realistic that it's likely that we're going to continue to have COVID in our communities and our hospitals and other care settings for months and possibly years to come. And as we've described, that's going to impact on productivity and the ability to reopen and switch on all of our services. That's going to bring additional complexities to the way that we care for people. And as Linda and Ian have described, and we all recognise in our organisations, people are physically and mentally worn out. So the NHS, I think, employs about 1.4 million people. You've got similar numbers working in social care, and these are the most hardworking, compassionate, talented people you can imagine. I think we've got a collective responsibility here to be realistic about our starting point. We have understandably got more patients waiting for treatment now than 12 months ago, but people are exhausted. So I think, building on what Linda was saying, a pragmatic plan built on what is possible with the welfare of colleagues at the centre of this is the best way to deliver sustained progress. It is that balance about absolute recognition. We all recognise the changes we need to make, and we need to continue to make progress with cancer care. We simply returning to where we were 12 months ago isn't a great position to be in, but it's a starting point. But I think we do have to have the welfare of all of our colleagues at the centre of this.
Righto, thank you. Ian, I don't know if has there been anything particularly in Kent and Medway that you kind of think, well, if we just had this amount of extra resource, we could increase capacity this much, or is it basically just constrained entirely by, as Suzanne pointed out, by the staff that you have able to do the work that they can do?
Yeah, no, look, I think, you know, the biggest issue through this whole pandemic and coming out of it has been workforce. You know, you can't just grow these people on trees, unfortunately, in terms of where some of those gaps might exist that existed pre-COVID. So I think there's a real balance that needs to be struck here, and would agree everything that's been said by my two other panelists in relation to a pragmatic approach to what we can do in the short term versus what's needed in the long term around a proper robust strategy to make sure that we've got enough people doing those roles that are so crucial to the NHS, even outside of the context of the pandemic. That there are issues about equipment and kit, particularly around diagnostics. But actually, I think the single biggest issue for us to address is workforce. And that's only been exacerbated by all of the challenges and issues that colleagues have had to face over the last 12 months. And I would just echo everything that's been said in terms of what is realistic and achievable, given that cohort of individuals that have been working on the front line have, you know, worked above and beyond to get the country through this period of time. So I don't think there's a quick fix in this space. And you said something about levers. I think most of, if not all of the levers have been pulled.
Gotcha. Fair enough. If I can just go to a couple of questions and comments people have made from attendees about some of the bottlenecks. I know we've only got 3 minutes left, but I was just curious for Ian and Richard, I think particularly kind of the specific kind of diagnostics bottlenecks that are related to equipment, or that are related to kind of actual like capital spend and kit. Like this is MRIs and CTs. Is this? I mean, do you guys have a lot of kind of mobile capacity that you've had to use? I mean, and would more of it help? I'm just trying to get a sense of like what the specific capital things that could make a difference are.
I'll go first. Yeah,
MRI,
CTs, endoscopy capacity, all of the above, as we described earlier.
Gotcha.
I think we've successfully done two things. We're clearly working far more in partnership now with other organisations. That is a genuine positive that's come out of this, and clearly we've been using the independent sector in a way that we probably hadn't been doing previously. But I think that level of capacity will be insufficient to see the change that we need.
Righto. Okay. So it seems an intractable issue. Well, I just want to ask one question. I think this is probably more for Linda. Just before we go, I've got a question from Andy McGuinness from Macmillan Cancer Support. It says, do you believe there's been sufficient political oversight and scrutiny by politicians on the work of the NHSE cancer programme?
Well, thank you, Andy, a colleague, for throwing in a nice question like that. I do think that actually there has been quite a lot of oversight of the cancer programme, and we have seen engagement from politicians. I think some of the interventions that were made certainly towards the end of the first wave, particularly from Secretary of State, did change some of the ways that treatment was being delivered. And I certainly think there's been an ongoing dialogue between both NHS England and Secretary of State. I think that's in some ways the role of the voluntary sector does play into this. We've been quite vocal during this. We've pulled together that report which showed the missing diagnoses. All cancer charities have worked together to come under the banner of One Cancer Voice to really be able to highlight concerns. And I guess I would say this, but I see this as the role of a critical friend during a time like this, to be able to support the system, but also to be able to hold it to account where we think it needs to be held to account.
Fair. enough. Brilliant. Well, look, I'm afraid we are out of time. Everybody. I'm very sorry if we couldn't get to your question or comment. And I'd just like to thank all of our panel. It's been fantastic. Ian, Linda, and Richard, thanks very much for your time on that. Do email any other questions you got or anything else you think I could help with. I just need to thank Pfizer, our sponsors, who I don't know if you've heard of them. They're a up and coming drugs manufacturer. And yeah, thanks very much to our sponsors, Pfizer. And thanks again to all our panelists and everyone who tuned in to watch. And like I say, sorry if we didn't get to your questions. HSJ's got lots of events like this coming up, so do check out the website to see what we've got coming up. Thanks again for your time. Bye-bye.